Welcome to this explainer. I'm researcher A, and alongside researcher B, we're diving straight into the statistical realities of modern healthcare systems. Specifically, we're looking at how these systems interact with the physiology of mature populations.
Exactly. We are strictly exploring the intersection of evolutionary biology and preventive medicine today. And let's be incredibly clear right up front. This is a fast-paced, purely informational lesson on medical statistics. We are not offering personalized medical advice, and we certainly aren't prescribing or discouraging any specific treatments.
Right. Our only goal here is to objectively evaluate the hard data behind routine medical screenings in asymptomatic adults.
So to really grasp the statistical realities of our healthcare system, we have to start with a very specific physiological concept: iatrogenesis. In medical literature, this simply means harm caused by medical healing or interventions. And for our purposes today, we're zeroing in on the adverse physiological responses triggered by completely unnecessary medical procedures. We're going to follow the data to uncover the unintended harm caused by well-intentioned, routine checkups in adults who have absolutely zero symptoms.
Okay, here's our roadmap for the day. We've got the concept of iatrogenesis as our foundation, and from there we'll hit four main topics.
We'll cover the changing screening math as we age, the biological cascade effect, data points in overdiagnosis, and finally, how to use all this data to maintain your evolutionary bodily autonomy.
Let's jump into Section 1, the changing screening math, age, and physiological reality. When you look through the lens of longevity and apply statistical models to a 50-year-old, early detection makes perfect mathematical sense. You find a problem early, you intervene, and you can potentially buy 30 or 40 more years of life. Plus, the body has a really high tolerance for surgical intervention and usually bounces back quickly. But here's the catch. At age 75, that risk-to-benefit math flips completely upside down. Many diseases found at this age are what we call indolent. That means they grow so incredibly slowly that you will statistically outlive them. Because mature physiology is much more fragile, the treatments, the biopsies, the surgeries, they often cause severe, sometimes permanent harm. And unfortunately, the medical system frequently fails to adjust for this very real biological reality during a standard 15-minute appointment.
To put a solid metric on this systemic failure, studies actually estimate that between 15 and 25% of all medical procedures performed annually in the United States are statistically unnecessary.
Yeah, and the really critical data point here is that this percentage climbs sharply after age 65. It's not because older populations are inherently sicker, it's because the system just keeps automatically applying 50-year-old screening math to 75-year-old biology.
Moving on to Section 2, the biological cascade effect, anatomy of an intervention.
Think of this like a domino effect. Here is exactly how the biological cascade builds. Step 1. An asymptomatic adult agrees to a routine test. Step 2. The test flags a false positive, or maybe a minor, biologically meaningless abnormality. Step 3. Because modern medicine doesn't really have a leave it alone button, this triggers an invasive biopsy or procedure. And finally, Step 4. The procedure itself causes an egodrenic complication. This cascade perfectly explains how a simple routine checkup can rapidly escalate into hospitalizations, extreme stress responses, and a sudden loss of independence for someone who literally walked into the clinic feeling perfectly fine.
We see this sentiment repeated constantly in the academic literature and clinical case studies. I felt better before they found it than I do now that they fixed it. It's a tragic irony. Take the clinical anecdote of Raymond, a fit 74-year-old guy with zero symptoms. A routine PSA test flagged a slightly elevated number. That led to a biopsy, which confirmed a slow-growing, low-grade prostate cancer. Trusting the recommendation for radiation, he went ahead with it. But afterward, he suffered from chronic fatigue and urinary urgency that completely destroyed his quality of life. The treatment essentially fixed a statistically harmless issue by creating a profoundly debilitating one.
Let's get into Section 3, data points in overdiagnosis clinical case studies.
There are severe hidden risks buried deep within these routine automatic pipelines. For example, in orthopedics, a routine DEXA bone scan often triggers automatic long-term prescriptions for bisphosphonates. The hidden risk there? Those very medications can actually cause atypical femoral fractures and jawbone deterioration. A statistically safer, non-invasive alternative is structured fall prevention, something like Tai Chi, which reduces fall risk by up to 50% with absolutely zero side effects.
Absolutely. And for routine PSA tests in older asymptomatic men, the intervention risks impotence and incontinence, whereas simply choosing watchful waiting is mathematically superior. The same goes for carotid ultrasounds. Surgical intervention carries the risk of a surgical stroke, when simply managing blood pressure and blood sugar yields much better statistical outcomes.
Let's shift over to gastroenterology.
The United States Preventative Services Task Force, which is basically the gold standard for screening guidelines, explicitly recommends against routine colonoscopy screening for average-risk adults over age 75. The objective data here is incredibly clear. Finding a slow-growing polyp in a mature body is statistically far outweighed by the severe procedural risks of the screening itself.
And the numbers back this up. Bowel perforation, which is a literal tear in the colon, occurs in roughly 1 in 500 colonoscopies. To put that into perspective, in a younger adult, that's generally a manageable complication. But in an older, more fragile adult, that 1 in 500 chance can quickly mean emergency surgery, a permanent colostomy bag, or even death.
What's really wild is that the cascade often begins before the procedure even starts. The bowel prep liquid required to clear the colon causes severe dehydration and serious electrolyte imbalances. Take the clinical case study of a 78-year-old patient named Margaret. She was completely asymptomatic but agreed to a routine scan anyway. The bowel prep alone caused her potassium levels to drop so dangerously low that it triggered irregular heartbeats. She ended up in the emergency room for 5 days of severe cardiac stress. She suffered immense, real-world harm simply preparing for a test that, mathematically speaking, she didn't even need.
Now consider the staggering 40% false positive rate for asymptomatic cardiac stress tests. Nearly half the time, if you have no symptoms, meaning no chest pain, no shortness of breath, the test flags an abnormality when your heart is actually perfectly fine.
But in the world of medicine, finding trouble basically mandates action. That false positive sends you straight down the cascade, right to a risky cardiac catheterization.
And if that catheterization finds a partial blockage, which by the way is incredibly common and often biologically stable in older adults, you receive a stent.
Yet when we look at the data from the massive ischemia trial, it shows that stenting in patients with stable coronary artery disease does not reduce heart attacks or extend life compared to just medication and lifestyle management alone. The cascade ends with patients on blood thinners, carrying major procedural risks, and statistically performing no better than if they had just taken a 30-minute walk every day.
We see very similar data in vascular screening. If a routine carotid artery ultrasound finds a silent, stable blockage in your neck, the recommended surgery, a carotid endarterectomy, actually carries a 2 to 3% risk of causing a stroke during or immediately after the procedure. It's a stark statistical irony. The surgery meant to prevent a stroke can actually dislodge silent plaque into the brain, directly causing the exact catastrophe it was meant to prevent.
Looking at oncology data, studies published in the New England Journal of Medicine show that up to 40% of breast cancers detected by mammography in women over 70 are indolent. Like we mentioned earlier, these are slow-growing tumors that would literally never cause symptoms or shorten a lifespan. But once that terrifying word cancer appears on a chart, the medical system's treatment button gets slammed down. That unleashes biopsies, radiation, and chemotherapy on fragile bodies completely unnecessarily. It's really a prime example of overdiagnosis leading directly to overtreatment.
All right, bringing us to Section 4, Evolutionary Bodily Autonomy, the Patient Protocol.
The crucial takeaway here is that you need to ask the right questions. Before agreeing to any routine screening, especially if you're over 65 and completely asymptomatic, you must rigorously evaluate the risk-benefit math using this exact protocol. Ask your doctor, what is the false positive rate for my age? If you actually find something, what are the realistic treatment options? What is the procedural risk of that treatment? What happens if we just monitor this and choose watchful waiting instead? And finally, is there a non-invasive alternative? Any physician who is operating purely on the data is going to welcome this kind of rigorous mathematical approach.
So, we'll leave you with this final, objective question to ponder. Is your routine medical screening mathematically extending your life, or is it simply triggering a biological cascade of anxiety and harm?
Understanding the statistics of overdiagnosis is exactly how you protect your evolutionary bodily autonomy. Thank you so much for joining us for this explainer. Keep questioning the data.
And we'll see you next time.